Well, thank you, Nancy, and welcome everyone to this evening's event. So pleased to see so many of you here. I'd like to begin by acknowledging that we are in Mi'kmaq, the ancestral territory of the Mi'kmaq people. And in particular, we're in Shubuktaq, which, if you don't know, means Great Harbor, or some people call it the Big Harbor, which would be Halifax. Also like to acknowledge that for over 400 years, people of African descent have been contributing greatly to the province, and do want to acknowledge that as well. Also like to see a few people up front here. We've got the Minister of Health, Michelle Thompson, Health and Wellness, a colleague of mine who I'm very proud to work with as Minister of Fisheries and Aquaculture. I usually go to the Minister of Health for more problems than she does coming to me as the Minister of Fisheries, I have to tell you that. And Ms. Karen Oldfield, who is the Nova Scotia Health interim CEO, who's doing a fantastic job in my opinion, but I can always read your minds, and you're saying already that he's biased. And to be quite honest, I have the pleasure of working with both these individuals. And on the far left, we have Craig Beaton, who is the associate member or deputy for Health and Wellness. So welcome to you all. So I'm not going to say anything more other than to introduce you and you to them, our Minister of Health and Wellness, Michelle Thompson.
Comes out. So good evening, everyone. Thank you so much for coming on such a blustery night. It's cold. I think it's the first time I've been really cold in about 6 months. So thanks for braving the weather. So my name is Michelle Thompson. I am the MLA for Antigonish, and this is my first time being elected. I'm a registered nurse and have been a nurse about 30 years. Half of my time I worked as a frontline healthcare provider, and the other half I worked in leadership roles of varying degrees. So here I find myself newly elected and as the Minister of Health. So it's my privilege to be able to talk to you a little bit today about some of the work that's been happening in healthcare. Certainly when we ran, our platform of healthcare resonated with Nova Scotians, and we knew that there were huge challenges, and there continue to be big challenges in our province. But we got to work very early. As soon as we formed government, we installed a leadership team that consists of the Nova Scotia Health Authority and also Department of Health and Wellness. And so for the very first time in our province's history, we now have the funder and the policymaker, which is Department of Health, working and meeting on a weekly basis with Nova Scotia Health, so that as decisions and issues come forward, we're able to plan as a system, and the right hand knows what the left hand is doing all the time. And there's certainly lots of contact in between those weekly meetings. There's lots of things that go back and forth between the two groups, and that synergy has been really, really important. It's been very, very helpful. And of course, there's other system partners. We're not exclusive. It's not just those two people or those two departments, but it does help us be more agile in terms of how we respond to problems and issues and solutions as they come up. So we also did a listening tour very early in our tenure. So I think by mid-September, we were on the road, the Premier and I, with the newly installed health leadership team, which consisted of Karen Oldfield, Jeannine Lagassé, who's the Deputy Minister, Janet Davidson, who's a thought leader and a very experienced registered nurse and leader in healthcare in not only Nova Scotia, but in the country, and also Kevin Orrell. And so we traveled from Neils Harbor all the way to Yarmouth over a 4-day period and spoke directly to healthcare workers and heard from them directly about what their challenges were and what they felt we should do in order to address the issues in healthcare. And we spoke to everyone. So, we spoke to not only healthcare providers, physicians, nurses, paramedics, but we also spoke when we were able to in hospitals to housekeeping and dietary and environmental staff, because of course their lens is very different, but it's essential to understand their experience. So we were really pleased with the engagement. And out of that consultation came Action for Health. which is our plan for healthcare. It is a strategic plan. It has 6 pillars. It's the first strategic plan that we've had in healthcare in at least a dozen years, probably more. And it talks about what our key initiatives are going to be, and it lists what our actions will be. And to accompany that, if you haven't had a chance to look, we do have an Action for Health website. And the website tracks our progress. Sometimes we can update things only annually, but wherever we can, we update them quarterly or monthly or however that works, and then we have a daily dashboard. So you can look at the previous day and understand how our healthcare system is performing. And we did that because we want to be very, very accountable to Nova Scotians. We want to tell you, how things are going, and we don't fudge the numbers. And so there are things that are coming along really well, and there are things that we wish were improving more quickly. But it's important that we communicate to you, to all of Nova Scotia, where we are in terms of our transformation of healthcare. So we do know that there are challenges, and I had a couple of people in my life as I was a leader that said we should never waste a good crisis. Every crisis is an opportunity, and so we know that there are problems in healthcare, and we have to seize this opportunity of political will, significant financial investment, a plan that's built on the voices of healthcare workers. We need to seize this opportunity and make it transformational moment in our healthcare, and that's what we're trying very, very hard to do. So tonight we'll share some of the things that are happening in healthcare, but we want to hear from you. We know that things are difficult, but we know that there are some bright spots as well, and we want to hear from you what you think would help. What do you think we should be focusing on? We'll tell you a bit about some of our initiatives, and if you could let us know what you think would be helpful and how, if you've had an experience. And we want to keep this dialogue going because it's going to take all of us in order to transform healthcare. So our people are our primary focus. We have a deficit in terms of the number of healthcare workers in this province. We see it not only in physicians and nursing staff, we see it in paramedicine, we see it in some of our allied healthcare professionals too, and we are very, very focused not only on recruiting people with it, growing our own workforce, bringing people to Nova Scotia to work, but also in terms of how do we retain the staff that we have, who have a lot of historical knowledge and experience. So it's very, very important, and we'll talk a bit about that. I think the other thing is just to say that Karen Oldfield will talk a bit about what is happening in Nova Scotia Health, and we'll continue the dialogue, and I hope you've had a chance to talk to some of the folks, and we may throw some of your questions to those folks. They are the folks that are closer to the ground than certainly I am, and we want to make sure that you have the information that you need before you leave tonight. So welcome, and I'm looking forward to our discussion.
Thanks, Minister. Do you want to go next, Craig? No? Hi, everybody. Nice to see you all here. And just in terms of a few brief opening remarks, I'd just like to touch on a couple of quick points. And before I do that, I would just ask all of the frontline healthcare providers who are here in the room tonight to just maybe stand or give a wave, because I know there's quite a few here. Yeah, so exactly. So I do want to thank you for coming, and I would like to make a point, to members of the public and others who are here tonight. It's so interesting to me that, almost 3 years ago, at the very, very beginning of the pandemic, the people that just raised their hands and stood were heralded as heroes, and we realized how much we needed and valued what they bring to Nova Scotia. And now, over the past few weeks and months, it's almost like the tables have turned. There's a lot of criticism. Our healthcare workers are they're not being treated kindly in our healthcare system, particularly in our ERs. And so I want to say to you, thank you for what you do and what you continue to do, even during very, very hard and difficult days. These are people, ladies and gentlemen, who go home after a 12-hour shift, feed their dog and say hi to their children, and then go back to work in many cases for overtime shifts. I don't think we really know what our healthcare workers have been through over the past 2.5 years, but before that too, because our staffing shortages didn't just happen overnight. They were certainly exacerbated by COVID, but they didn't happen overnight. So folks have been working in extreme conditions for a long time. We see across the country that people are leaving the professions, whether they are a respiratory technologist or a physician or a nurse or an LPN or a CCA. And we know that we have to work very hard at retaining our healthcare providers. So I do want to talk about recruitment and retention tonight, so I'll just leave it at that, and thank you for coming tonight. We have lots of experts here, so I think I'll be shocked if we can't answer all the questions. Technology. That was Freudian, wasn't it? Technology, wow. I may have to just stand up and talk very loudly. Technology is one of our challenges in the healthcare system. And, you know, just to put it in perspective, we have nurses, we have healthcare workers across the spectrum, we have physicians who are joining Nova Scotia Health. They're coming from universities and colleges, and they don't know a day without the internet. They don't know a time without a cell phone, without mobile connection and so forth. Today's generation are highly reliant and very skilled with digital applications and technology generally. And I don't think you'd be surprised if I told you that that's not what we find in our hospital system. We're actually really, really, really far behind the 8 ball when it comes to connecting all parts of the province, to even having internet functioning at top speed all across the province. So we've got a lot of work to do to get our system up to snuff in terms of the technology. And that's something I'd like to talk about tonight as well. So that is a challenge. It's a challenge for our healthcare workers, but it's also a challenge for patients, for families, and for those who want more control over their information and their file and access to their blood work and their appointments and all of the things that would really help us to do a better job of self-managing our own health and wellness. Third thing I'd just like to touch on is scope of practice, and we had a lot of questions submitted. I don't know if there are folks here. Actually, I do know there's one person who submitted a question. We did get a lot of questions in advance, and I hope through the course of the night we'll be able to answer those questions and of course those who we have here in person. But the scope of practice is something that we deal with very regularly. So just to, I guess, explain what I'm talking about, if we think of the spectrum of those providing healthcare services, so we may have a CCA, an LPN, an RN, a nurse practitioner, a physician, a general practitioner, a family practice physician, a specialist, and so forth. If we had every person in that chain working to the full scope of what they are permitted to do by law and what they are permitted to do by their college, their regulatory bodies, then we would be able to cover a lot more territory with perhaps a fewer number of people, if you see my point. What we have to do is make sure that our healthcare providers are working to the top of their scope. And I'm going to give you an example of exactly what I'm talking about. And it's also an example that shows the kind of work that's going on within the system. So bear with me. and Craig, I will give you a chance to talk. Just stay with me. About this time last year, we gathered a team, folks from Nova Scotia Health, a couple of people from the department, and a number of individuals from the Dalhousie family practice clinic. And we had an assumption that we wanted to prove, which was we felt that the practice should be able to take on more patients, that they should be able to take some people off the list. And so we put a team into the practice. Everybody was a willing participant, and we had a number of industrial engineers and others who really looked at how that practice was organized. And it's a top-notch practice. No issues with level of care or anything like that. What we were trying to do was see if we could stretch it, see if we could get them to be able to take on a number of people off the list. So the team went in for 4 days, Thursday, Friday, Saturday, and Sunday. By Friday night, I got a call from our lead person on the team, a woman by the name of Tara Sampali. You probably saw her on the news maybe this week in relation to the mobile clinic. And Tara said, Karen, without even working too hard, it's agreed we can take 2,500 people off the list. She said, it's only Friday night. So they worked through Saturday, they worked through Sunday, and Sunday night she called and said, guess what? Everybody is very comfortable that we can take 3,500 people off the list by Christmas. So this project, I said it started about a year ago, and in fact, once everything got organized, it was later in the spring. So the Christmas I'm talking about is this Christmas. So how were they so sure they could do it? How they were so sure they could do it is by recognizing a simple fact. It takes between 60 and 90 minutes for a physician to onboard a new patient, on average. So every time a physician is taking on a new patient, there's a lot of work that has to go into taking the history and doing all of the things that need to be done to take that patient on. And what we concluded was that, and we put together a rapid onboarding team so that the physician wasn't necessarily the person that had to do all of the administrative work in doing the onboarding. And by doing things like that, having the physician doing the things that only the physician could do, the nurse practitioner doing things that that position could do, the administrator doing the things that they could do, and so forth, we were able to put in place a model where, in fact, yes, they are taking 3,500 people off the list. And they also were able to find new ways of educating our residents, our medical residents who also work at that clinic. So this is a model that is now able to be expanded across the province. We're going next to, I think it's New Glasgow and Truro and I think Antigonish and one on the Dartmouth side. So we think when all is said and done that we will be able through the full optimization of the scope of practice of folks in these clinics to take approximately 20,000 people off the list. Approximately. So, exactly, thank you. Because it's pretty common sense. Pretty common sense. And like many of the things that we're finding, you know, there are common sense solutions to the problems, but you have to focus and you need to do it. You need to do it. So I'm going to stop simply by reiterating something that the minister just said. Folks, there is no lack of political will. None. 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 Nobody calls me up and says, do this, do that, do this, do that. They say, Karen, do as much as you can, as fast as you can, please. Money is not the object. We have been given, last year alone in the budget, another $413 million. So nobody is saying, you've got to You got to really, watch the bottom line. Of course, money is important, but it is not a barrier to our success here. The only barrier to our success is us. And when I say us, I look around the entire room. It's us. Because if we can't do it, then who is going to do it? Nobody is saying we can't. We can. But we all need to be in it together. We need to give the solutions. Why we went to the healthcare, the frontline healthcare workers. They gave us many ideas, which we are implementing as quickly as possible. But the hole was pretty deep. The hole was deep. And we dug to the bottom. We're starting to climb out. It is going to take time. I look forward to what people think, your comments, your questions, and most especially your solutions. So thanks for coming tonight. Over to you, Craig. Oh, going to Nancy.
Yeah, no, sorry, thanks. In the interest of time, I don't have any real opening remarks. I'll leave those with the Minister and Karen. I think there's lots of people in the room with probably some great comments, so we'll switch it over.
Okay, thank you. So the next piece of our evening then is the questions and answers. So as I said, we have some pre-submitted questions that I will probably start with, and then we'll move to the room and we'll kind of just take turns going back and forth, making sure that we get to as many questions as we can. And I will also preface that by saying that it depends how many questions we have. We have our evening together tonight, but I can also confidently say that if you have questions that were either pre-submitted or that you have questions tonight, if we don't get a chance to answer them, I have been in enough of these sessions that I do know that every question will be responded to in some way, shape, or form. I also wanted to just make sure that just to kind of set some kind of expectations around we have the people with the mics that are going to run. I would ask that if you have a question, we'll take your one question, and then we'll go to another person. And if you have a follow-up question, we can go back, if that makes sense to everyone, just to kind of make sure that we give everybody an opportunity to have their questions asked. I did find in some of the other sessions, or we found in some of our other sessions, that sometimes people have questions or concerns that are about very specific incidents that they would like to have a conversation about, and that is absolutely understood and why you would want to have that conversation. So what I would do is, if you have those kinds of questions, I'd invite you to perhaps wait till the end of the evening and or to submit them on a card and ask them to be addressed, just because the panel wouldn't really be privy to a lot of that information ahead of time, so it's hard to answer the questions. So we've had a few that it doesn't always get to the resolution that people want because we don't have access to the information that you might need that's specific to your examples. So if that makes sense, I just look for little head nods if that makes sense to people. Thank you. And so, yeah, so we are going to try to move things along. Some of the questions are really amazing and in-depth. And so if you submitted a question and you don't hear it, but you hear something similar, we tried to consolidate some of them so we'd get the general, the over sense of the questions. So, got to get my glasses on. Usually I print this off in really big font. We did not do that tonight. So this first question is, what are the steps taken to reduce wait times on family doctor registration? Are there specific plans or improvements for children with special needs?
Singer, all my mic technology. So there is a number of things that are happening around wait times for physicians. So if you, we are looking, I guess it depends on the service is what I would preface it by saying. So if you're waiting, and I think that question means specifically to specialist, is it specialist family doctors? So the practice optimization would be one of the things that we are looking at in terms of supporting physicians already in practice. So there are a number of physicians and nurse practitioners throughout the province that offer same-day, next-day access. And there are other physicians that don't currently work under that model. So the practice optimization team is one of the tools, and it's not just one team, there's a couple who would be able to go out and work with practices in order to look at the flow in their clinics, in their practices, to better understand how they can optimize and get better access. Because we know there's attachment, so people who who are on the Need a Family Practice Registry or who are waiting to be attached, they actually have access through Virtual Care Nova Scotia. Everyone is eligible, but we do know there's a portion of the population who are attached to a family practice, but their access is minimal. They may have to wait 4 or 5, 6 weeks. Sometimes we hear about that for an appointment. So working with that clinic to optimize practice is one of the things that we're doing. The other thing is, particularly for episodic complaints, we've implemented a new model, which is a nurse practitioner and a pharmacist who are working to the fullness of their scope in several communities: Cobequid, New Glasgow, New Minas, and Bridgewater, I think. And so what we've been able to do is work with nurse practitioners and pharmacists. They work in concert together, so people can go to pharmacy and have their episodic complaints particularly looked at. So prescription refills, folks that maybe need an INR, addressed, different things like that. And pharmacists also now, many of them have access to your blood work, so they'll be able to look and reach out to physicians as well. So that's another example of something that we're doing. There are walk-in clinics as well for episodic complaints. We know that primary care is a significant issue, and we are looking at building the resources and looking at teams. So the physician, our more senior physicians generally had larger practice, worked on a fee-for-service model, and our newer physicians prefer a different model. And so it's not always one for one. So sometimes we need to put 2 physicians or a physician and a nurse practitioner as we see retirement. So looking in each of the communities, looking at the assets, looking at what the needs of that community are, and trying to build primary care so that not one size fits all would be some of the things that we are doing to address access for physicians.
Yeah, sure. Thanks. So I would just add a couple of other things that we're also really targeting, and there's some folks actually in the back of the room here that had a huge part to play in this. Just over this past weekend, you would have seen some of the mobile clinics that are popping up around. There was one in Antigonish and one in Halifax, and those resources are able to divert patients from the ED. Some of those people that don't have family docs going and getting prescriptions refilled, et cetera. I think over this course of the weekend, there was over 200 that were served, which I think is a big success, because we know that demand in the system is really high. I'll turn it to Karen here in a second too, but the other piece I would add is recruitment. So, we're laser focused on recruitment. We have a team right now that's actually in the UK meeting one-on-one with family docs. Prior to going there, they had over 200 people that had showed an interest in actually wanting to speak with somebody about, coming and setting up shop in Nova Scotia. Just to date so far, we've already recruited 85 new physicians, 45 of which are family practice docs in this year. So we're on track to hopefully surpass the recruitment numbers that we had from last year, which was the highest number that we've had in a long time. So I would say there's a number of pieces on the recruitment side as well that are the teams are focused on.
Yeah, thanks, Craig. It's interesting. 85. That's since April.
That's right.
So that's this government fiscal year. So since April 1, 85 physicians. The graduating class at Dalhousie this year, in July, they will graduate the highest number of family practice physicians in the history of the province, which is great. So that's a start. Then we need to encourage those graduates to take jobs and remain in Nova Scotia. That's challenge number 2. So each one of those individuals has received a job offer. So it's, that is why in part I opened my remarks with talking about how important it is to engender a culture. We as members of the public have to continue to show that we value and need our healthcare providers, because we need them to stay here in Nova Scotia. doctors, physicians, healthcare workers, they're like everybody else. If they feel welcome, they're more apt to stay. If they don't, they won't. So I'm excited about the prospect that we may have, well, we do have a high number of grads this spring, and hopefully many of them will choose to remain in our province, and many of them will end up in the central zone. Just to add, I guess, to the question briefly, the other aspect, and we did get a couple of written questions on virtual care in Nova Scotia as well. So this is, if an individual does not have a family doctor, they are eligible to register for virtual care in Nova Scotia. If you register for virtual care in Nova Scotia, you can go online, you can have an appointment. It works quite well for the most part. The demand is high. I look at the numbers every day, and they're actually increasing every single day. They do increase. Not only does the demand increase, but we also have an increasing number of nurse practitioners and physicians who are providing care through virtual care in Nova Scotia. But it's not 24/7, 365. So that's a challenge. And it's interesting. So if a person has an appointment with virtual care, a couple of things can happen. The provider may be able to resolve the issue on the spot, or the provider may refer to a specialist, or the provider may say, you need to be seen. If the provider determines you need to be seen, you are referred to a primary care clinic. So you will be seen at that clinic, and interestingly enough, the clinics are flowing quite well. So the time limit to be seen is quick. And now what we're seeing is that in some cases it's faster to be seen at a primary care clinic than it can be waiting 5 or 6 weeks to see your own family doctor. So that's a secondary challenge that we're facing. And the other thing that we're finding is that everybody wants virtual care. So not just those who are currently on the Need a Family Practice registry, but everybody wants to have access to virtual care, because in some cases it's a lot easier to have your prescription renewed over the phone or through a Teams call or a Zoom call than it is to wait at your doctor's office. So from that perspective, we are looking at how we can enlarge the virtual care offering to those beyond people who are on the Need a Family Practice list. So I'll stop there, go to the next question.
Okay, thank you.
Acknowledge that we didn't answer the part about kids with special needs. And so I'm not sure if there's a specific clinic as an example that someone is trying to access at IWK, and certainly we can follow up. I do know that there has been some work around children and youth who have neurodevelopmental health concerns, and Minister Brian Comer is the Minister for Addictions and Mental Health, and the neurodevelopmental clinics would sit under his file. And so I know that there's been work done particularly around access to care and new targets for children living with autism. And so I think if I had more specifics, if we can maybe reach out and find out what that is specifically, and we can discuss that. But there certainly has been movement in terms of how do we support children and families who have someone in their home, in their life, that is living with special needs.
Thank you. I think so. We'll try to do, I think, a one-for-one in the beginning if we have. Is there anyone who has a question out in the audience that they would like to read? We have our runners right there and there with their mics. Is there anyone that has a question? Okay.
Hello. just wanted to know where Nova Scotia and BC are the only provinces to not allow back unvaccinated healthcare workers. Why is that with the, I guess, shortage in services that we've got?
Thanks for the question. This was asked in Truro as well, and it is the policy, current policy of NSH, and I don't see that changing at any time soon. You know, answer, not going to change.
So there is no answer, like there's no reason for it? Is that the answer, or is it just not going to change? Like,
oh, there's lots of reasons, but it's not, we're not going to argue about it here tonight. I think that's, it's been a decision, and I'm executing on the decision. So it's just not, you know, we're not intending to look at it again anytime soon.
Thank you. So this question actually kind of speaks to what you mentioned in your opening remarks, Karen, around scope of practice. So someone has submitted a question that is, her husband spent 2 months in hospital, and was struck the most was the absence of nurses' aides on most floors. Only one unit had them, and they were excellent. Are there plans to expand their use?
So I can start, and I'm sure other folks will fill in. So the model of care in a number of different areas, it does vary based on the acuity of the patients who are in that certain area. So I think probably talking about continuing care assistance. So we do have a significant, or an improving situation in regards to continuing care assistance. So first of all, they're the backbone of our long-term care and much of our home care, and they also work in hospital providing direct patient care to folks. And we were very, very proud to increase the wages for CCAs a year ago, and they received a 23% increase, and they are now, you know, many of them are getting $25 an hour, which was a significant step for us. And for them, we were so proud to be able to do that. So what that did, prior to being elected, I worked in long-term care, and we just could not fill our vacancies, and we continue to struggle. But since that raise came, there are over 1,000 continuing care assistants in the program this September, which is significant. And certainly long-term care facilities are now able to take people who have prior history as caregivers to come in and train them also on site. So as that workforce builds, we will be better able to implement them throughout the system. And we know it'll also stabilize our long-term care facilities as well, which is a key aspect in terms of how we look at access and flow through our hospitals. So we have a number of people who are waiting for long-term care. We know we need more spaces, but in some cases, long-term care facilities weren't able to fully staff their facilities because of this gap. And so very pleased to that workforce is building. So we expect that there will be around 800 graduates in the spring, and that's across the province. And so that will help us. And they don't all work in long-term care. Some of them come to the hospital. So as we build that workforce, you can expect to see folks working in those roles throughout the system.
Thank you. Are there any other, I know, who's next in the audience, I guess, not are there any other questions? Do we have anyone else that has a question? Okay, over here. And then we'll go here, and then here. I said I feel like an auctioneer when we do this. Then you.
My name is Kim Carter, and I work with the ALS Society of New Brunswick and Nova Scotia. And one thing I was wondering about when you did your consultations across the province with healthcare professionals, and I commend you for doing that because they are working on the front lines every day and they're the people in the know, but also wondering about the numerous nonprofit organizations that also work with that population on the front lines every day as well.
So I think you and I may have met online. Yeah, we did. Yeah. So after we did the tour, I did approximately 25 to 30 stakeholder engagement with a number of different, just a variety of stakeholders who definitely have, you know, an interest in terms of how we support people living in community. We looked at like the colleges, regulatory colleges. We talk to associations, professional associations, because not all of our health professionals are regulated just yet. We talk to diverse communities as well to better understand how we can serve folks better. So those were done just under a year ago. I know after the legislature rose, we went and spoke to those folks and got some really good feedback. And some of the feedback, we don't work fully in silos. Some of that information is helpful for Minister Barb Adams, who's seniors and long-term care, who also encompasses home care, continuing care, and then Minister Comer as well, who's addictions and mental health. So we do work together, but we continue to, and I still will meet with people on a fairly regular basis, some associations, as will the department. It's not always me. Sometimes it's better if you don't meet with me. You meet with the people that know things a little bit better than I do. So that's ongoing as well.
Thank you. I'm going to take another a submitted question, and then I'll go back to our audience if that's okay with everyone. So this question is a submitted question. Can you explain how we, the public, can advocate for emergency services to be included in the Bayers Lake facility?
When they don't know the answer, they get me to do it. No, it's okay. At Bayers Lake?
Yep.
Look, it's a great question. So I think that the way I look at this, everything's on the table. So, you know, we know that with our population growth, number one, that we sorely need additional emergency health services, ERs in Metro. The population boom is here, but it is also in the corridor between Halifax, Bridgewater, Halifax, Windsor. We've seen unprecedented growth. And so at the same time, we've seen a real, I guess, it's like a tornado. It's very difficult circumstances at all of our emergency rooms and our emergency departments across the province, but particularly in Central Zone where we have the highest population. So I think it's a very good suggestion. Advocating, I would say, write to me, write to the minister, write to both of us, and please, you know, help us to help you. As Jerry Maguire would say, it's the best answer I can give you. Yeah. The more people who are advocating for things that we need, the easier it is to make the case for it.
Can I add? I would just also add that what's really important is, you know, of course we want emergency services, and I think any of us that have ever gone to an emergency room, you know that they triage us. They give us a Canadian Triage Acuity Score. We get 1 to 5. And the lower the better, really, in some ways, in terms of how sick you are. So the other thing that's really important for us to do is understand through analytics at Nova Scotia Health, who is coming? What are the reasons that people are coming? And the answer isn't always another emergency room. Sometimes often the answer could be an urgent treatment center so that people can go for things that they don't expect but are not life-threatening. It could be that we need a collaborative care clinic in a different way. So what we really need to look at is what are the access points and what are the highest and best uses of the facility there. And it you know, maybe it isn't an emergency room, but it may be an urgent treatment center or it may be a primary care clinic. So I think because of that population growth, understanding the demographics of the folks that are there, understanding how people move and where they're seeking services and how we can make sure, because what's, you know, I remember when my kids were small, what was manageable at 4:30 at night before we all went to bed was not as manageable at 4:30 in the morning, if that was a belly pain or an earache or whatever. But if I had access to an after-hours clinic, perhaps I would have been able to have that seen versus going to the emergency room, because I was, despite being a nurse, was quite a nervous mom. So, you know, so I think we have to really look at what the communities need and how we can kind of give people tiered care so that only those big emergencies are going to emerge. Right now, a lot of people have to go there for a variety of different things.
It's just a fact, a stat to leave you with. At the moment, in Nova Scotia, 80% of persons appearing or going to an emergency room have a family doctor. It's not the unattached, it's actually the attached, and that's what's really scary, because that means, it goes back to what the minister said a little earlier. It means people are coming to the Emerge because they can't get in to see their family doctor. So that opens up another whole series of issues. So 80% of people going to Emerge have a family doctor. So that's a problem we have to solve.
Thank you. We have a question up at the front here.
Thanks very much. I enjoyed hearing your, I think I would describe it, a commando approach to the new development in care at the Dell Family Clinic. I'm wondering how many physicians are in the group tonight. Could we have a hands up if you're a physician?
Quite a few.
Okay, well, maybe 4 or 5. Because I think the elephant who's not in the room when it comes to scope of practice is the physician population. And while I appreciate the commando approach to change, the question is it going to stick? I feel that nurse practitioners should be allowed to practice independently. And I must admit, I don't know whether at this point in this province that's possible. But I think they should be allowed to do that as a way to increase access to primary care. So that, including just one other point, which is that I think you need to engage physicians on a wider scale to get them to buy in to the need for people to work to scope of practice in order that everybody can get care.
Thank you. So I'm going to start, but I think maybe Dr. Alexiadis will get you to come on up here and finish. I agree. We do all need to work to the fullness of our scope. And I think we need to enable each other. And over the number of years, as we've gotten more complex and our health system has gotten more complex, our scopes have changed. I do feel, as a nurse, that the physicians have bought in to the nurse practitioner role. And I want to be respectful of all my colleagues. Nurse practitioners are not family physicians, and they have a wonderful role to play. And I think the answer lies in these collaborative teams so that we can always, scale folks up, just like our family physicians. They reach a certain point and they move us on to specialty services, and then specialists will go to subspecialists. I think it's really important that we create that team environment of care so that everybody's supported and we can collaborate, and when we've reached the edge of our scope, we can pass it off to our next most responsible person. But I'll let Dr. Alexiadis finish.
Thank you, Minister, and I didn't even pay you to say that, did I? But thank you very much for saying that. I think every healthcare provider in this province wants to give care to patients. Family doctors, nurse practitioners, dietitians, everybody. I think what we have to do is break down those silos. And so sometimes there are some barriers in family practice because we're working so hard and our heads are down on the desk. We don't have time to get up and have these conversations. But we all want to work together. So the scope of practice issue is the one that will help to save us. If we all do our work and all work together, we will have bigger capacity in the practice. So I think there's not a person who doesn't agree with that, including physicians. But we're just so busy right now that half of them are ready to retire like me, but I won't retire yet. And the other
Because you're
half,
having too much fun, you said.
I am having too much fun.
It's getting better all the time.
It's a good time to be in primary care because I'm a department head, so I'm not only just a family doctor. Well, I'm not. I am a family doctor, not just, but I'm also the department head for family practice. So I recruit new doctors. I try to keep the retiring doctors from retiring if they can do other work. So the whole thing is that we're all trying to go towards all that stuff that you've heard up front. It's an exciting time to be in primary care. So comments like this, coming to these type of events are very good because we're listening, and we will do what you say. Thank you.
Yeah. Okay. Thank you. That was. I know. So there was a little clapping moment there that I think everyone wanted to just cheer. So thank you for that. I'm going to go take another written question, and then those of you that are thinking about things you want to ask, I'll give you a second to kind of formulate that. So the next question is about a little bit about the recruitment piece, I guess. But what progress has been made in amending how healthcare professionals not educated in Canada are deemed qualified to begin working in our system?
Go ahead and start. I'll pick it up.
Okay, I'll start, and I know there'll be others that will finish. So there has been a lot of work done in terms of how we support internationally educated graduates. And there are folks who have been born and raised in another country and have been internationally educated and are trying to come here. We also have a number of Nova Scotians and Canadians who, because of whatever reason, have chosen to study abroad. And they've gone to places we hear often, Saba, and we hear Ireland as two examples where folks have gone away. And so then when they try to return, it's more difficult for them to come back. And there's an issue around residency sometimes, which I call the musical chairs of medicine, which I'm sure make all the doctors cringe. But there's often more physician candidates, residency candidates, than there are seats. And we're working really hard. We're increasing the number of residency seats that we need for the types of doctor that we need, as one example. We've also worked with the colleges to look at what are the requirements to come in. There is a Canadian, first you come in, like there is a Canadian, a national requirement first, but there's also a provincial requirement, and that's what we have kind of purview over. So we've been working really hard with the colleges to understand how we can streamline, looking at practice-ready assessments. So physicians that are trained in different places will come and they'll work with physicians and have their skills assessed. And really for the first time in my career, talking about competency-based assessments. We're also looking at cohorts of individuals. So as an example, there's a wonderful program that started particularly focused on the Ukrainian refugees that have come here because of war and how we work with them. So we are working with Ukrainian navigators who've been hired by Nova Scotia Health, and Karen can fill in some gaps. How do we work with them? But what they've challenged us, not only provincially but nationally, is, we depend so heavily on records, but their records, many of their records are not available because of the war. And so how do we figure out what their competencies are and where can we use people to the best and highest use? There are some folks who will come here, nurses or physicians, who will not probably ever meet the criteria that are required to be fully trained, but that's not to say there is not a place for them in our healthcare system. So can they work as clinical assistants? Is there another opportunity for them in our healthcare system to use those skills and that passion that they have for healthcare to the best and highest use? And so that's also been a challenge for us, is to find these committed healthcare professionals who've come to Nova Scotia and see how we can integrate their skills and their talents into the system. So.
Thanks. I would add, so the minister's talked quite a bit about sort of some of the work that we've been doing in relation to physicians, but I would say we're equally as focused on some of the work with the College of Nursing. And, there's been, Karen opened up and talked about the need for all of us to sort of be rowing in the same direction. And I think, all of the stakeholders that we work with, the colleges, whether it's in the province, we've met with the Royal College across Canada as well, and everybody's really knows the need to really look at these and come up with innovative solutions. So the College of Nursing, they've looked at a number of ways to streamline the licensing, and I think as of August, there's been over 200 international educated nurses that have been licensed as in the province, and that work will continue. So I think that's up roughly about 60 more than where we were last year. So I think that just points to the fact that people are really sort of taking up the challenge of looking at things and doing things differently. So.
The minister's reminding me of our bridging program.
Thank you.
One of the things that we're trying so many different things. We have 3 universities in Nova Scotia where students can go to study nursing. They can study at Dalhousie University, they can study at St. FX, and they can study at CBU. But those seats, I don't know, off the top of my head, it's just under 500. I think we would graduate. I think it's something like 478 nursing students a year. And you may have heard that every graduate has been offered a position with Nova Scotia Health for the next 5 years. So it's still not enough. So how do we do this? Well, we can work with each university as we have, to increase the number of seats. There's only so much physical capacity, so many professors, so many labs, so many, the physical constraints takes time to add new buildings, but all of that is certainly under consideration. So then you look at other ways to do it, and that would be finding people in Nova Scotia or in other parts of Canada who have received international education, and what we've tried to do is find them and then bridge them. So we have a very innovative program in place right now where we identify where they receive their education and what do they need to do to actually qualify to be licensed here in Nova Scotia. Is it a month of work? Is it courses? Is it help to take their exams? Like, what is it exactly? So once we identify the folks, then we're able to put them in cohorts. If it's additional education, great. We find it, we do it. If it's help to prepare for an exam, if it's shoring up their English language skills. So it's whatever it is, we're trying to provide that help, because the folks, if they've already received a level of education, it's a lot faster to get them ready for the workforce. The other thing we're finding, though, which is very, we know this for a fact, and it's something that we have to be working with our universities, is that our nursing graduates are coming out of school and they are not what is called floor ready. They're not ready to go. And that's kind of scary, because that's additional time, it's additional education, and it's, I don't know, I find it a little bit ironic, I guess would be a kind word, that we're graduating people who aren't ready to go. And so we work with the universities so that they can be as ready as possible when they do graduate. So with respect to the nursing professions, I guess the final thing that I would add, and I got a great message from Dr. Sani last week, and I see Dr. Sani's leaving Dalhousie to go to join McGill. Anyway, he has been working with our team to open pipelines with universities in India. And he's very familiar with a number of the high-ranking institutions in India. And the email that he sent to me last week, he's pretty sure he's got a pipeline for between 75 and 100 Indian nurses who will graduate from Indian schools and who will work in concert with Dalhousie to be ready to go to work in Nova Scotia if we have jobs for them. So I think that's fantastic, and I haven't even had time to send him an email. And now I guess I'll be sending it to a new president. So anyway, Deep's been very, very helpful over the past year in doing this bridging and in making his own contacts and his network available to help us.
Thank you. Does anyone have a question? Oh, right over here.
Thank you. My name is Andrea Lance Powers. I'm a specialist physician here at the QE2. When we go through medical school and residency, we have zero training at all in practice management and patient flow. So I had read a bit about that family practice model that was coming through, and I found that to be a very innovative and exciting thing. Is there any move to expand that to specialist clinics? Because my group, we're looking at spending $30,000 to get a consultant in to our group of 9 specialists. And we think it's worth the investment because we feel like we really need to work on our wait times. We probably have so many ways that we could make our care more efficient, and people then won't be waiting a year to see us. Thankfully, most people don't need to wait longer than a year to get in to see a urologist, but that's still a long time. I've heard from family physician colleagues that neurology has sometimes a wait between 2 to 4 years. So those family doctors who have patients waiting 4 years to get care are working at the limits of their practice. They'll see those patients back multiple times for something that they really are having problems dealing with, and they need that specialist to give their opinion. So I think if we could find a way to have us all work more efficiently, we could really improve family practice care, because then the MDs would feel better support, their patients won't be waiting so long, and we would be able to retain family physicians as well and get people seen so they're not on these endless wait lists.
It's a great point. So 3 things immediately come to mind. I'm going to ask the minister to speak to virtual hallway. I'm going to talk to the team that could come and look to it. And then I also want to talk about, I hate to use the word, but I'd like to talk a little bit about accountability. So three things that would just touch on. So do you want to start with virtual hallway, and then I'll come back to the team?
Yeah, so I'm not sure if you're familiar yet. Oh, yes, you are. We talked about it the other day. Yeah, of course. So virtual hallway is actually, it is virtual care, but it's actually a hall. It's a place where family physicians and nurse practitioners can speak, can take a patient that they feel that they're on the edge of their scope with, or need some clarification or some direction or care planning with. And they can add this patient to a specialist physician, and virtually they can consult on this patient together, and the family practice physician or nurse practitioner is then able to, based on the advice from the specialist, able to care for that person. Sometimes it may expedite, sometimes it may be something that is, I don't want to say simple, but when you're working in family practice, particularly in Nova Scotia, if you're in a small practice, it really is heartening to be able to reach out to a specialist and to be able to hear that you're on the right track, or this, what is the level of triage, or what could I do differently? Have I maximized treatment, as they wait to see you in person? So the virtual hallway is new. And it is starting with a couple of specialties, and it has been very effective, and it's quite reassuring. There also is a new pilot that's happening in the emergency rooms in rural Nova Scotia, where you actually can have virtual access to specialty care in psychiatric care as well, and mental health care. So that's been very helpful as well, so that folks are not traveling long distances for short appointments, or perhaps you get there and you don't have all the blood work, or like any number of different combinations. Or perhaps you get to the specialist and a phone call or that consult would have been what you needed to have care in your community. So it is an innovative program, and we're really looking forward to the results of it, and to save time and travel, and also to make sure that patients get care closer to home with a provider that they know and are used to while they wait for specialty.
And I think, Minister, virtual hallway is a technology which was created by Nova Scotian physicians right here that are from Halifax. So I think they've created it. We're piloting it. It's working well, and hopefully we can incubate them to take that across the country. So it's positive. What I was going to say on the team that can come in and have a look at the practice, there's no reason that's restricted to family physicians. So if that's something of interest, Tara Sampali and Grayson Fulmer would be only too happy to get your email and at least have a chat and decide if you want to have the team come in and have a look. So I'll just say to all, the team that we have is going to be available for any family physician who wants to, try to optimize, have a look at their schedule. Like, I mean, I'm not a family doctor. Maria Alexiadis can speak to this better than I can, but we did have an opportunity, the minister and myself and Jeannine Lagassé, to, we had an opportunity to see a family, a clinic, a medical clinic in Copenhagen. The minister was invited to attend a conference, and we went there and we saw a clinic, and they made a very big decision about their scheduling. These were doctors there were 3 physicians in the practice, and they were not able to see their patients for 6, 7, 8 weeks. It was causing a lot of stress. They were not able to provide the care that they wanted to provide. And so they made a really scary decision to go to same day, next day practice. And that meant that they basically got rid of their appointment schedules. And so, a patient would go on their website the night before. They could go up to 24 hours before and put in an appointment. So it would be same day or next day. So the physician looking at next week's schedule would see nothing but blank space. So very scary for a physician who relies on patients for their income. What they found was that it was always full, always full, always full. They never had to worry about it. And so there are scheduling, there are tools that we have available that can help physicians to get out from under some of the backlog. So we have these tools available, and we're happy to make them available to physicians who are interested. And the only other thing I was going to say, I mentioned accountability. One of the things we find is that there's different payment models for physicians, and not to get into it, but there are a number of so we're working with a group of physicians who are basically what I would call salaried physicians, APP physicians. They're not fee for service. And in general terms, these would be physicians that we would hope to have between 1,100 and 1,300 patients. But not all are in a position where they have that many patients. So some have a lesser number. And we are looking at ways that we can help those physicians to increase their panel size. So if they have a panel size of, say, 500 or 600 or 700, how can we help them to get up to 1,000? How can we help them to get up to 1,100? So do they have capacity within their own skill set and their practice area and their patient population, depending on the demographics, of taking on more patients? So we're working in collaboration with Doctors Nova Scotia to see if there's ways that we can support and encourage those physicians to be able to take more people off the list.
Thanks. I'm going to go back to my submitted list. How do we better address rising issues in mental health, specifically in rural communities where access is poor?
Thank you for that question. So I will say that there's been a couple of things. So again, Minister Brian Comer is the Minister of Addictions and Mental Health. He's very passionate. He's a registered nurse as well and has a background in mental health. So there have been another number of things that have been going on. There are a couple of day hospitals. There's one that was recently announced last week in Sydney, and there's a day hospital here to support patients with getting daytime access and then being able to be at home at night. We're looking, when we look at the physicians that we need to recruit to the province, we know that there is a gap in psychiatry coverage. And we've been able to work, or Minister Comer and the team have been able to work to identify a number of clinical associates who are able now to work with a psychiatrist. They have been psychiatrists in their previous home and are now able to work. And so they have the skills but aren't able to fully register here at this time. So while they get more experience, they're working with psychiatrists, and that has been very, very successful, particularly in Cape Breton. And also in rural Nova Scotia. Just recently, I mentioned the fact that we now have in the Eastern Zone, they're trying this electronic or virtual referral, so that patients, don't have the barrier of travel. They don't have the barrier of, all of the different things to leave their community. Sometimes they don't have transportation or what have you. So being able to see someone in a supportive environment in the emergency room to get the care they require. And so the day treatment hospitals that we mentioned, the virtual care option in a supported environment, and also trying to increase the number of clinicians that we have who are able to deliver care are some of the things that are happening. And we can check with Minister Comer. I'm probably oversimplifying the work that's happening. He's working very hard on universal mental health care as well. Yeah.
Thank you, Minister. Are there more questions? Anyone? Oh, perfect. Down here and then over here. So, yep. I know it's like that rudeness to point, right? But
So thank you for having those sessions, and I'm glad that I'm able to ask my question. I wrote it, so it's hopefully it will be more clear. So access to chronic disease care, such as heart failure. I'm a heart failure specialist. So access to chronic disease care is very unequal within the province. How do you plan to collaborate with the healthcare professional in place to remediate this and support the other zones having to deal with increased workload until good care is accessible in all areas? I think there is, certainly amongst all my colleagues, we think there is a need for provincial-wide mandate for some very important disease, such as cardiovascular disease. And also, I suggest my help. We do have a heart failure network that we work together that we're creating. So I'd be happy to help to find some solutions with you, but I'd like to hear what you have for plans for chronic disease.
So I'll start a bit. Certainly chronic disease care is essential. We know that it happens across the province, and it's really essential in terms of reducing admissions and making sure people live with an optimal quality of life while having quality or living with chronic disease. So there has been some early work done with the Inspired program. I'm sure you're probably familiar with that, and that model has been successful in looking at scaling that model up. What I would say is if you have ideas on how we can do that, we are very interested to hear what those plans would be. Again, further to the points earlier about working to the fullness of our scope and looking at the community assets, making sure that folks have the training they need and that we have good relationships. So that network will be essential, making sure that folks have access to the best clinical guidelines. And there are a number of issues. So, speaking about respirology, heart failure, the other concern that we hear a lot of is actually endometriosis and chronic pelvic pain care, and how we support family practice clinicians in making sure they have access to best practices and specialty services. So I think these folks maybe are going to say a little bit more, but we are very interested in how we scale that. Nova Scotians have a significant amount of chronic disease. We live with a lot of comorbid conditions here. And I will just say as an example, some of the things that we saw, another innovative program that we saw, and we do have it to a large degree here, is around our OAC clinics, our hip and knee clinics, and how they're able to work with people with chronic pain while they wait for surgery to make sure that the joint is strengthened, that they have some weight loss. And when they work in that supported clinic environment, often a number of their comorbid conditions, if they have them, improve as well. So there's a lot of space for us to fill, but we are very focused and interested in expanding that program, and happy to hear from you.
I'm very happy to hear that, because when the new government was elected, we reached out, me and Heart and Stroke, to have an appointment to talk about heart failure. So I guess we can readdress this. We can ask to have an appointment with you to talk about heart failure in our province.
Yeah, I certainly feel welcome to reach out. It's been a busy year, and I don't know about that appointment, but certainly we're happy to hear. There's a number of things that are underway, and we continue to look for different solutions and trying to reach out. And we also have to remember we have the same people doing all the work. So sometimes we have to do things in stages, but certainly we're happy to hear from you. Yeah.
Yeah, thanks. I would just add, just onto that, so we'd be absolutely happy to continue to have the conversation. Karen has already referenced Dr. Tara Sampali, and I know that she and her team have been doing some work with one of your colleagues, Dr. Giacomantonio, around sort of a similar issue. So I think we'd be more than interested to hear what you and your team have to say, because it's in the early stages of having those discussions.
Okay, thank you. Okay. I think somebody right back. Yep.
Hi. Mine's the same question, but in a different area of chronic illness. What is your plan to support primary care providers to effectively treat patients who have chronic tick-borne infections? And that treatment should also be based on the most recent effective evidence-based guidelines, because that care is unavailable in Nova Scotia.
Sorry, could you repeat the
Chronic tick-borne infections. So
okay.
Borrelia, Babesia, Bartonella,
So what I would say is there are some standards. I think we would have to get back to you specifically about that. I know a little about a lot of things, but I can't speak directly to that tonight. But we're happy to get you the information and reach out to you.
Last week in the media, you said to go to the ICCS clinic in Fall River, but my daughter has been going there for 8 years and has received no care for her chronic tick-borne infections in those 8 years.
Mm-hmm. So that would be something, I can't speak to that in this environment, but I'm happy to speak with you afterwards. Yeah.
Okay.
Yeah.
Thank you. Are there other questions from the, oh, there's someone. Again, I apologize for the pointing, but I have to just direct the microphone.
So recently in the news, we heard about the meeting between the federal Minister of Health and the provincial and the premiers about CHT funding and increased funding. And according to the news, what the federal minister said was that there may be more money or an expansion of dollars into CHT for the provinces, provided that the provinces expand their key health indicators and they build a world-class health data system. Allegedly, or according to the news, the premiers immediately told their ministers of health not to commit to any strings attached to that funding. So what evolved was a bit of a fiscal food fight, which, as taxpayers know, is not new between the federal level and provincial level of government. So my question is, specifically speaking to Nova Scotia, how do you see the workaround of getting our hands on those dollars that we really need to do this work with this type of ongoing acrimonious relationship?
So I'll start, and I'm sure my colleagues will finish. So the first thing I'll talk about is the importance of technology and our ability to collect and understand data. Like, we need those enhanced systems. And I will tell you, Minister Duclos and I have a good working relationship. We speak on a regular basis, and we have talked about the gap that we have in data, not just for our patients, but also in our workforce. So very, very essential. We know that there's a whole different way that we would like to see money come, instead of just per capita, which is fine now because our population is increasing, but we also need to look at the demographics. So just like we talk to physicians and family practices about, it's not always just the number of individuals that we have. If you have a practice, or if you have people who are 20 years old and don't need a physician, is very different than a population that's older with comorbid conditions. And so we're trying to understand what it looks like when we fund that model. So we will continue to have dialogue with the federal government. We have some very innovative ideas. We sell ourselves well here. We talk about being a small province. We're 1 million people, just over, and our ability to be agile and incubate really good innovative technology, as well as plans of care, and we want to be able to measure that. So what I would say is the conversation is ongoing. My relationship is good with Minister Duclos. There is more to say. The first ministers, our premiers, and the Prime Minister certainly do have some conversations to have, but that it's not, to me, an all or nothing. We continue to work with the feds around what the work that's happening here and tell them, and we will partner wherever we can with them in order to advance our initiatives.
I think that's fair. I mean, the minister is an elected person. I'm not. What I would say to it is that at the end of the day, the data is important, and evidence-based decision-making is important. I can certainly tell you that at Nova Scotia Health during COVID, a lot of work was put into establishing a number of benchmarks across the board, and you can see some of that online today. Like, we can see how important the data is, and we have a lot more data today than we had 3 years ago, showing even more how important it is. So I'm a data geek. I'm all about the data, and I think that the Minister Duclos, as an economist, is in the same mind frame. One of the challenges is that it's kind of dumb, really, that you have individual provinces with data that's not shared. So it's very difficult for, a federal government to make good decisions when they don't have across-the-board data. You may have heard Dr. Teresa Tam on this point through COVID. I mean, it's kind of dumb that this country, how great it is not in a spot where we're sharing common data. However, we are where we are, so what we have to do is do the best we can and then partner as much as possible on pilots and every little way we can wedge our way in there to find our way to the dollars, so to speak, that we need to recruit and to retain and to pay and to make sure that we're able to provide a sustainable system for our people here in Nova Scotia. I don't know if anybody watched Rosie Barton last night, or maybe it was yesterday. I saw it last night on, I guess, her Power and Politics show, and she interviewed Minister Duclos, and she also interviewed people across the country on this very topic. And at the end of the day, there's only one taxpayer. They don't really care if it's federal or provincial. They want, they want access to health care when they need it, where they need it, et cetera. So, people need to speak up and make sure their voices are heard, and we need to make sure that we find we're collegial, we're collaborative, and we find every which way we can to partner with the feds to make a win-win.
Okay, there's a submitted question that kind of ties into this, so I think I will just, I'll read it out just because it ties into the IT question. And the question is, when will you work with IT experts to ensure that records are shared with appropriate primary care staff, including nurse practitioners, following reports after emerge visits or hospitalization?
Yes, yes, yes. Yes. We are, I think we've talked about it. It's probably been answered before. It really is important. And all the things you don't know about before you become a politician. I got a mandate letter, and I thought, oh, what's a mandate letter? Well, I soon found out when I read it. So in my mandate letter, which is my direction from Premier Houston, we talk about one patient, one record and what that could look like. So I think as patients, as Nova Scotians, we want that record. But certainly when we were on tour, on the listening tour, clinicians were asking for that record. That's what I heard loud and clear. And I did have an opportunity to go to Vancouver and understand what that one patient, one record meant to the clinicians we did a tour of a hospital, and it was pretty significant. So one patient, one record is where we need to go. Oh, we also went to Denmark, and I was absolutely fascinated by their ability to manage their own data. After age 16, everybody has an app on their phone, and their health data is right there. And so I had a lot of questions about that when we met with the family physician. And so, we're going to get there. It's going to take us some time, and it's going to be a significant investment. But I do believe it will, one, democratize our healthcare so that we have more influence over it and understanding of it. And it will also help our clinicians provide better care for us. So I think it's where we need to go. It's a huge investment, but it's worth it. Yeah.
Actually, I was going to say, Minister, that Dr. Bussey's here. I think she was here. She's still here. There she is. Come on up here. You come on up here and talk about this. She is the guru here in Nova Scotia, so let's hear what she's got to say. I know, you weren't prepared, but here you are.
Hear me? I'm not prepared. My name is Christy Bussey. As a clinician, I'm a hospitalist. I do inpatient medicine at the QE2, and I've done that for 13 years. And for the last 8 months, I've had the role of Chief Medical Information Officer with Nova Scotia Health and the IWK, working particularly on one patient, one record, and the gap that we have in the healthcare system with sharing of information. We feel that as clinicians every single day. I have specialist and family practice colleagues in the room with me, and we don't have a great way to communicate with our patients, with our colleagues, with emerge inpatient systems, between systems, and even the data, which you're asking about sort of data and access to data. We don't have systems right now that talk to each other to be able to share data, to work in real time. So sort of that vision of what we have of the healthcare system is as you're describing, having a healthcare record that can be shared, that you as a patient, me as a patient outside of my role as a professional, can have access to be able to communicate, because we have not evolved in the healthcare system yet. We have an opportunity to do that now. The way that we've evolved elsewhere in the world, like with your banking apps and your way to communicate that way, we haven't done that with healthcare yet. And we're finally, I'm so excited to say, after 13 years of working here, I'm originally from Newfoundland, working here in Nova Scotia, to have that landscape to be able to move forward with those changes that clinicians and patients have been asking for a really long time. Yeah, thank you.
Thank you. Oh, okay. Question here. 1, 2, 3. We got you.
Thank you very much for having this tonight. My name is Sandy, and I am a 20-year paramedic here in Nova Scotia. We've heard lots of good stuff about physicians and nurses and CCAs and LPNs, but we have heard nothing about the paramedics of this province. Any of you who read the newspaper, look at social media, watch the news, you'll see that this is we are past crisis stage. We are in disaster mode when it comes to our emergency service that you call when you are in need. So I'm sorry, I'm a little bit emotional about this. We work for a private company in this province. The ambulance service is managed by a private company in this province. We are not managed by the province. We're not government employees. And so there has really been no retainment strategy that we have seen from the inside looking out or from the inside looking in. So we are looking for a commitment that there's going to be some movement on retainment of paramedics in the province, because I'm 20 years in and I'm wondering what my next career is going to be. And I shouldn't be doing that right now. And the people of this province deserve more than that. They deserve high quality care. They deserve professional paramedics to show up at their door in a timely fashion, not in 2 hours, 3 hours, 5 hours, whatever that looks like. And the second thing is, you were talking a lot about scope of practice. So paramedics in this province, we have a very small scope compared to what our scope should be. So we are more than capable of working in a variety of settings that we're currently not working in, and we would provide some great care to people if we had that opportunity. Thank you.
I'll start just quickly. I just want to say you're absolutely right. We have our paramedics in this province are the finest paramedics in North America, at least. And we do have a number of things that have to happen in paramedicine, and I'm going to let ADM Beaton speak about some of the things that are happening. But the care, absolutely. And there's also some work happening around how we can ladder primary care paramedics to advanced care paramedics to critical care paramedics, and how do we provide a range of opportunities. So I just want to acknowledge the paramedics in the room today. We have been focusing a bit more on inpatient, but the pre-hospital care system in this province is filled with unbelievable practitioners, and we're really grateful for the work they do, and they are under an incredible amount of strain. And so we'll talk a little bit about some of the things that are happening to support paramedics. There's still much to be done, but I do want to acknowledge the paramedics in the room today.
Yeah, thanks very much. And I'm actually going to get somebody, Jeff Fraser, to come up and talk as well. But first, Sandy, I want to just thank you, for your service for 20 years. And I'll look forward to next week, possibly seeing you at the Long Service Awards if you're there in a different environment. But I would say, the people in the room that know me, I would think that they would say that I'm certainly very passionate about paramedics. It's been a file that I've had for a number of years. And certainly appreciate the hard work that paramedics do on a daily basis. I do know that there's frustration out there. That's true. However, I do want to highlight some of the positives, and I'm going to get Jeff to come up here and talk about it in a minute. But I do also just want to say that, because of the paramedics like yourself, we are actually being seen as leaders, like world renowned. So Jeff can talk about a conference that he was at with in North America with a number of international experts, and Nova Scotia was actually the area that they were looking at most. And a lot of that because of the work that you and others are doing. Scope of practice is certainly one of the things that we're looking at. So Jeff, why don't maybe I just turn it over to you to give a couple of highlights.
Make sure this thing's on. All right, I'm not a great singer either. So great question, Sandy. We've got a lot of work to do within our paramedic service here. Within the province, your comment on scope of practice, those are things that we are looking at right now to make sure that paramedics are working to their full scope. I think the paramedics themselves have demonstrated over the years, things like CECs, how paramedics showed up and were able to staff an emergency department at night, really shows the untapped potential that exists within that type of profession. We do have a lot of work to do. At the moment, we're really working on separating out our transfer work from our emergency and urgent work so we can actually create some capacity. This problem that we're experiencing with paramedics, although it is a phenomenon we're dealing with in Nova Scotia, it is not one that's not been, it's a challenge everywhere in North America. We have to change. I think tonight the panel talked about not doing things status quo, and the EHS system is no different. We've got a lot of things that have to happen here. When it comes to recruitment and retention, you asked a good question about that. In April this year, we started a paramedic working group. It did focus on recruitment. We're really swinging it now into retention, looking at the people that are in the workplace. I mean, it's great that we want to bring people in and attract people, but I think it's also important that we make sure we look after the people that do work in our service. And so I know there are a couple paramedics here tonight. I'm a former paramedic, and I do appreciate what you do.
Thank you. I think we have a question up here too that's...
Thank you so much. So I was really thrilled to hear Minister Thompson mention the recent trip to Denmark. And that's one of the reasons that I'm excited about that is because of their home and community care practice. And so we know that in Nova Scotia we have a growing senior population. And if I were to make this personal, I am very interested because of my parents' health care situation and my grandmother who's 90 wanting to stay at home in her home. When I look to Denmark and other countries like Denmark, I get very excited because I think there's some solutions and ideas out there. So my question to you would be, what lessons did you take away from Denmark, particularly with home and community care? And full disclosure, I do work for VON, so yeah. I'm quite passionate about home nursing.
I had a hint. She told me that she was coming, and I said, if you see me check my phone, it's because I took pictures of a PowerPoint presentation when I was in Denmark, and so I wanted to be able to refer to that, so I'm not texting. Actually having a look at some of the things. So we were invited. There were 3 provinces that were invited to go to Denmark, and Nova Scotia was one of them, and we were really pleased to be able to go. And there were a number of innovations that we saw. Certainly their government structure is quite different than ours and complicated. And I don't know if there's any municipal councillors in the room, but actually home care former. So actually home care is the responsibility of the municipalities in Denmark. And so it's very close to community, right? And so it's very community focused. So we learned a lot of lessons from them. They do have a home first approach, which we have had in Nova Scotia for a number of years, and that really means that we want to return people to their homes as much as possible versus having them come into hospital where often they decondition, particularly if folks are older, and then maybe move on to long-term care facilities. So they do have long-term care facilities, very enabling in terms of their approach in long-term care. So they do have a number of home programs, as an example, where they would do virtual rehabilitation and rehabilitation programs. And I was able to bring some of those things back to Minister Adams, who's looking at what is the potential. We were in Copenhagen, so of course it was very densely populated, and certainly the home care that's delivered in Metro would look different than it would in Antigonish or Badak or Digby, places like that. Very much home first. They talk too about loneliness. So one of the things that folks do, and I don't know if we would accept it or not, at age 65, whether you need it or not, somebody comes in and has a cup of tea with you and they screen you for a variety of different things. They also screen you for loneliness. And so that was very interesting to us, how loneliness contributes to people's decline. And so there are things to learn. We also learned about their home-based programs. There are things that we currently offer routinely in hospital that they offer in community. And one of the things would be chemo to go. So that was a really innovative idea that I had not heard of that concept before. So it's not for all cancers, but it is for some cancers where people actually have their chemo, it's in a pump, and they actually move about the community in their daily business to the point to which they're able and feel well enough to do that. So that was very revolutionary for us, and we were able to speak to and work with Denmark about how that was implemented there as something that we may be able to consider in Nova Scotia. Even the pictures. Here was a gentleman receiving chemo, and he was just going about his business throughout his day versus, spending all this time in hospital, potentially exposed to, infections or other people and all those things. So that was really something. So their rehabilitation program, again, their program for folks waiting for hip and knee, very intensive rehabilitation program. It delayed, when they began it a number of years ago, it delayed or put people in a different pathway. Up to 60% of their wait list actually was managed. So they either had delayed in surgery and had good quality of life, and some folks actually had the strengthening and the weight loss and some of the supports around injections and things. They didn't actually need surgery. So there were a lot of learnings that we continue to unpack. But we brought things there too. I don't want you to think it was all just one way. Actually, some of the folks that we met with actually have followed up with some of the innovations that are happening in Nova Scotia, and we are building our partnership with them because we feel that it's very, very mutually helpful for both them and for us. So lots to learn, but I will just say, if I can brag for a minute, that we have a lot to offer, and our clinicians here and our innovation team is really world class.
Thank you, Minister. We did a home and home. So we did go there, but we had the opportunity to have a number of people from Denmark come to Nova Scotia within the last month, and we are looking at forging a partnership around clinical trials around chemo to go, learning some of the home care strategies. I have to say this, Steve, because I can just think, what it would be like to call up Mayor Savage. Mayor, we got some people that are coming out of the hospital and they need home care. Like, this is how it works there. Literally, in each municipality, the council looks after folks when they get out of the hospital. And I don't know how that would ever work in Nova Scotia, but anyway, I guess we don't have to worry about it at this particular time. Anyway, we did learn. Oh yeah, you're 67, so okay. Well, I'm not even going to comment. Anyway, it was the one thing that the folks in Denmark learned when they came to Nova Scotia and want to learn more about and include in our partnership was our work around robotics. So we haven't really talked about that tonight, but we are building a real center of excellence here in this province around robotics. And it's really exciting because depending on which robot, which treatment, we would be either number 1 or number 2 in Canada at this moment in time. And there's some real expertise, and what's very interesting about it, it comes back to data too, because part of this is artificial intelligence related. We are able to obtain data that helps clinicians in their endeavor, but also we can find out, who might be susceptible, who needs this kind of care, who needs that kind of care. So the data and the robotics go closely together, and I will just tell you, and we can brag, we will be able to brag about this. Don't like to brag till we solve some of our access issues. However, there are bright spots in our system, rest assured.
What a great way to kind of cap off our evening. And I am sorry because I know we didn't get to all of the questions and there were still some there. So if you have questions on your cards and you didn't get a chance to ask them yet, please just leave them with us. And like I've said, I know that those questions are answered. And I just, I want to say thank you. And thank you to all of you that have come out, that submitted questions and asked questions. And thank you to our health leadership team. I always say it takes a lot of courage to come in front of a group of people and put yourself out there to answer these questions. And I really feel like I think that deserves a lot of credit. As I mentioned before, this is being recorded and you can watch it later, or you can, others that were not able to join us are able to watch it. So thank you very much and safe travels home.
Thank you. I just want to thank you all for coming again. And I do want to acknowledge the healthcare workers in the room. I know it's been difficult, and I do want to assure you, the Premier has given his word, and I continue to give mine, that we will work hard. We know that there is lots to do. And I want to thank you for hanging in here with us. We are trying. We're open to hearing from you. We want new ideas. And I just, I just want to acknowledge that it was tough before the pandemic, and the pandemic has made it tougher. And I want to encourage you. I want you to feel hopeful that we are going to keep trying to make things better. So thank you.